I can tell you further that we have made this webinar because we discovered that there are a lot of questions about reception and maybe also the treatment of Ukrainian refugees in certain countries of Western Europe, but also in other countries around the world. And that's why we made this webinar possible. I have to introduce myself. I'm Hans Rohlof, psychiatrist from the Netherlands. And later on, my colleague Simon Groen, also from the Netherlands, will have the discussion at about 8 o'clock. That's Simon. And we thought that this webinar is very suited for persons who don't know anything about refugees, but also about for persons who want to check if what they know about refugees and about the treatment and reception of refugees is still at stake at the moment. We think that there's a lot of attention to Ukrainian refugees, and you could say, why not for refugees from other parts of the world? I think the attention for Ukrainian refugees is also because we have a sort of common enemy in the world at the moment. The Russians, of course, and the Russians are seen as a common enemy of all democratic countries. And maybe that's a little bit different than, for instance, other wars where refugees came, where there was a civil war of certain groups in the country. But that's a more philosophical question, maybe. I think we have to profit from this attention for the treatment of refugees to allow this knowledge to be used not only for Ukrainian refugees, but for all refugees. I think we should take this opportunity to discuss refugee treatment all around the world and in all the different regions. We have two excellent speakers in our webinar, Dr. Waini and Dr. Bala. And I want to introduce to you first Dr. Waini. He's a professor of psychiatry at the University of Illinois Chicago College of Medicine, where he's also director of global medicine and director of the Center of Global Health. And for over 30 years, he has been conducting research both with refugees and migrants in the US and in post-conflict countries, focused on mental health and violence prevention. Next to introducing him, I also have to introduce the two interpreters who probably have troubles when I or Dr. Waini or Julia take to speak too quick. So please, Sonia and Sophia, please show yourself and show that you are with us. And thanks for letting you see. You can close your video now, I think. Thank you. And let's continue by also saying that please do not use the chat for questions. You can put your questions in Q&A. And if you put your questions in Q&A. We will also use these questions for the discussion. Dr. Groen has already made some questions. Of course, if you have questions, just put them in Q&A and we will look at it. I will now give the floor to Stephen, who is at the moment in the capital of Tajikistan. So he's not in the United States, but speaking from Dugambi in Tajikistan. Stephen, I give you the floor.
Thank you very much, Hans. It's a great pleasure to be here today to join you and Julia and others. So I'm going to reflect on the experience of Bosnian refugees coming to Chicago. So starting in the early 1990s, Chicago very quickly became a city of 30,000 Bosnian refugees over a very short time period. Some of these refugees came through refugee camps in Croatia or in Turkey or in other neighboring countries. And then a large amount of them were settled to European countries, especially to Germany, and then were further migrated from Germany to the US, including Chicago. Why so many in Chicago? Because Chicago is a multicultural city. Chicago has a very developed refugee resettlement system, and Chicago is a place where there has always been migration from the former Yugoslavia. So there's many Serbs, Croats, and Muslims from Bosnia and Croatia and Serbia already there. And so that also caused some interesting tensions in the city as well. But the city welcomed them. And I'd say the American resettlement system is a system of what someone has called tough love, maybe especially compared to some of the European systems. So people come and live in the community. They get an apartment in the community. They come through organizations which get them an apartment, get them English classes, get their kids registered in school, and get them jobs. They need to get jobs as soon as possible. And the emphasis is on them establishing financial independence. What this means for a lot of people is that, you know, you might have been a doctor, but now you are delivering pizzas, or you're working in a factory or in a hotel. And so this is frustrating for families. Children, when they go to school, they might not speak English, in which case they might be put into a special bilingual education program, depending on the schools. There were several NGOs that established psychosocial and mental health programs, and those programs hired Bosnians as what they called bicultural workers, kind of like case managers. And they provided counseling, they provided medication treatment, they provided, case management. And many of those happened to be physicians in Bosnia who are refugees themselves. And then there was also what we call in the US mutual assistance agencies, which provided kind of more like community level support and problem solving for the community. I was involved with Bosnians in Connecticut and New York, and then I moved to Chicago in 1995 and started working with them, and we established a Bosnian mental health program at an NGO called Travelers and Immigrants Aid, which is now called Heartland Alliance. There was a collaboration between our university and the in the State Department of Human Services and this Travelers and Immigrants Aid. And there we provided mental health services to thousands of Bosnian refugees. We did some kind of surveys over the years, and we estimated that about 8% of the population received mental health services, but we also estimated that about 60% had above a minimal threshold level of PTSD or depression. So we thought that there was quite a significant gap, and I'll come to that in a minute because that has implications for service delivery. I just summarizing here, telling you that one of the other things we ended up doing is developing a family-oriented program that we called CAFES, Coffee and Family Education and Support, which you can read about if you want. But these were multiple family groups for Bosnian refugees. And we also did a lot of work in the schools. So let me organize my talk by giving you some lessons learned from all that experience, reflecting back now, many, many years after. So I'm first going to tell you about don'ts, and then I'm going to tell you about do's. And I have about 5 or 6 or 7 points under each one, and then I'll wrap up. So don'ts. I'd say don't focus on just those willing to self-select to be mental health patients. You know, what we found is that overwhelmingly females more than males would prefer to self-select. The typical patient would be a mother in her 40s or 50s who was very depressed and had PTSD. And of course they needed support and help. I'm not saying they didn't, but there are many who suffer and who need help and who can be helped, but they're not necessarily seeking mental health care. And so I think that that calls for other strategies to try to reach them. Another, which I'll maybe say when I get to the do's, another don't is don't over rely on medications. We know the medications are good. We know they can help people. We helped a lot of people with depression and PTSD with antidepressant.
Seems that Stephen is a little bit frozen at the moment, so maybe it's the Wi-Fi at the hotel where he is. So we will wait a few seconds till he's back. Yes, it disappeared completely at the moment. That's too bad. Maybe it's because of the. There he is back. Yeah.
Here I am.
Okay.
There's like thunderstorms here, and maybe that's what caused it. I'll just keep going.
You were telling about antidepressants, Stephen.
Okay, so you know, people would get better on antidepressants, and then they would stop the antidepressants. Many people, because they didn't want to be on those, and so that was difficult. And I think more education is called for to help them to understand why medications. But I also think that we underutilize psychotherapy, both individual and group psychotherapies, which I think can be just as effective as medication and maybe more acceptable to people culturally. Another don't was don't expend all your mental health resources on individual treatment for a small number of needy people. I mean, there are for sure a small number of people who want to come to your clinic a lot, want a lot of sessions, want a lot of hand-holding, and there, you know, they will use up all of the resources. But from a kind of public health point of view, should you be expending all of the resources on these few people, or should you find a way to distribute them more evenly amongst other people who are not as assertively help-seeking? I think we need to strike a balance. Another don't is don't assume that one size fits all, especially for the young. And we did a study in which we followed children and adolescents over several years, and we divided them based on our research findings into 3 categories: thriving, who are doing extremely well, managing, who are kind of getting by and doing okay, and struggling, who are really having problems. And I think they each need very different levels of care and support. And I think sometimes, at least in America, our kind of democratic notion of we should kind of give the same to everybody, goes wrong here, because some people need different things. The thriving ones need to learn how to apply to college and get financial aid for college. The struggling ones need to learn how to stay out of jail or drug abuse or alcohol abuse. Don't assume that resilient processes that were learned in country, like in Bosnia or in Ukraine, during their flight, or that were learned in their first resettlement site, is necessarily the same resilient processes that are going to help them where they are now. In many ways, they can be different. So, for example, we had many people who would say, like, our kids are okay here. It's not a war. We don't have to worry about them. We have faith in our kids. We believe in our kids. We believe in society. Well, there are a lot of dangers in Chicago. And if parents aren't helping their kids to stay safe from those dangers, then they can have trouble. And another really important set of resilient processes has to do with patriarchal families and gender balance within families. So the kind of like rigid patriarchal traditional culture that, say, Bosnians come from, doesn't necessarily adapt well to a situation where women and daughters are working and going to school, and they're living in a society where there's more assumption of more equity. So this becomes a real challenge. All right, my last don't is don't over prioritize some protective resources over others. So we in mental health, I think we tend to really value the protective resources related to emotional coping, related to attachment, related to interdependence. And these are really important qualities. I'm not denying them, but there's other really important ones too that I think refugees need help with. One is providing information, and another is protecting against threats, and another is preparing for transitions. And so I think that we need to help strengthen those coping strategies as much as the ones that our kind of psychological theory tells us are so important. Okay, I'm halfway through. Now I'm going to go to the do's. Develop a tiered approach, T-I-E-R-E-D, tiered approach, multiple levels, following something like the IASC guidelines, where there's broad psychosocial interventions delivered at a community level. Then there's somewhat more targeted interventions like at a family or small social level, and then more targeted interventions at those at risk, and then specialized services for those who have clinical needs. And it goes without saying that at all of these levels, to utilize not just mental health specialists like psychiatrists, but to utilize community workers, bicultural workers like the Bosnian physicians I said before, to utilize nurses, to utilize lay health professionals, lay health workers, teachers, community workers, youth workers, faith workers, that kind of stuff. Another is really commit to working in the community to address stigma and improve mental health literacy. So, it goes without saying that in Bosnia, there really wasn't much of a tradition of seeking care, seeking mental health support for common mental disorders. Psychiatry and mental health was all about schizophrenia and severely mentally ill. And I think, some of that trend might exist in Ukraine as well. So I think people don't expect that they should seek mental health services for depression or PTSD. They need to be educated of why this could be helpful. And I don't even know that it's important to emphasize mental health services. A lot of times we talk just about health. Here in Dushanbe, for example, we talk to people about women's health education, women's health support. We don't even frame it as mental health because then you're inviting so much stigma. The most common problem people have is sleep disorders. So why don't we just talk about helping you to sleep better? Another do is work in schools and help children and families. Schools are a great place to deliver services. Schools are places where kids need help. Kids get bullied. Kids have learning problems. Kids have peer relation problems and attentional problems. And also families come to schools, and you can help strengthen the relationship between family and school. You can go to family meetings. So schools become a much less stigmatized place to connect with kids and families than does like a clinic. So consider using the school as a basis for your work. Another do is develop and implement family-focused approaches. Well, I already told you I'm a believer in that with cafes, but it was the Bosnians, who really taught me why do family-focused interventions, because I'd never met a culture of people who were showed so much solidarity amongst their family within the generation or across generations, and really supported one another, and in spite of a lot of hardship. And yet we recognized together that families could use some extra support, some extra education, some extra guidance, some extra skills and knowledge to help them parent in these really challenging new conditions. So I believe in that model of cafes. We did a randomized controlled trial. We showed improvement. And just to say, we kind of updated it, and we kind of married it with PM+, the WHO's PM+, and we did another round of low intensity, what we call low intensity family support intervention, with Syrian refugees in Istanbul. And we found it to be very helpful. And we have data that shows that it was positive. It worked in decreasing PTSD and depression and improving family resilient processes. And the main way that was different from cafes is cafes didn't try to treat people's PTSD. It tried more to strengthen family resilience process. In this new low intensity intervention, we also included stress reduction strategies that we taught adults and children, and we thought that was very successful. So I recommend family interventions. Okay, another do is utilize group and individual psychotherapy methods and continue something like a stepped care model. Well, that's what we're doing here in Tajikistan. We developed a stepped care model for women's mental health and primary care. And if you aren't familiar with that, I'll just explain it really briefly. The first is a group that's run by women and peers that is basically an empowerment model, and it's teaching them, it's doing what we'd call psychoeducation, it's doing self-management strategies, it's communication strategies, advocacy strategies. And a lot of people will get better from that. If they don't get better from that, then give them individual psychotherapy, a brief individual psychotherapy, like something like interpersonal psychotherapy and evidence-based therapy. If they don't get better from that, then give them antidepressant medication. So we don't immediately go straight to antidepressant medications. Consider some kind of model like that. And I'm not saying it has to be rigid. There are some people who do immediately need medication because they're so depressed they could never be in a group. But there's ways to work with that. I think you get my drift. I got 4 more, and I'll be quick. Another do is to work with law enforcement, partner with law enforcement to address issues like safety in the city, domestic violence, and also make sure law enforcement doesn't inadvertently kill or harm any people who are mentally ill in the community. We had that happen to us. One of my favorite patients was shot by Chicago police because they thought he was attacking them with a knife. He was, and he was a little crazy. He had bipolar disorder. He was manic, but he was manageable. But they didn't understand, and they didn't understand him, so he died. And there are many other cases of, the refugees are afraid of law enforcement because they're afraid of people in uniforms. I mean, maybe not all, but many of these Bosnians were, so they didn't think the police were their friends who could help solve problems with them. But I think they are. So I think it's important to build bridges like that. Another do is provide support and resources to host families. If you have families in Poland or Moldova or other countries who are hosting these families, it's a lot of demand and a lot of stress on them. And they also need strategies of how to work with the refugees. Do you encourage them to tell their story or not? What do you do when they get very sad? So provide them with some guidance, some support, some resources. Another do is teach self-management utilizing like CBT strategies. So I'm a big believer in that. Not everybody needs to go for clinical treatment. A lot of people, if you teach them these strategies, they could do them on their own and they can get better. Or at least let them have a try at that before you invest individual psychotherapy resources. So you're not going to have enough individual psychotherapy resources to go around for everybody. So things like deep, slow breathing, grounding, journaling, drawing, dancing, walking, these things can be very helpful to people. Meditation, yoga. And then my last do is find ways to focus on men. Men have a hard time, coming for mental health services. So you have to find other ways to reach them. One great way to reach them is through sports, and then introducing kind of psychosocial dimension into soccer or basketball or whatever, or working through their coach. Another is this method that we were excited about for a long time, testimony therapy. People like to tell their story. Some people like to tell a story. Men especially like to tell their story of what they've been through. And that can be therapeutic. We found that decreased PTSD and depression. And the people never really had a sense that they were in treatment. So those are my don'ts and do's. Lessons learned from many years ago from work with Bosnians. I hope that they might be informative to the challenge that lies ahead. Thank you.
Okay. Thank you, Stephen. There are some questions for you, so I think you should stay a little bit in your video on, because Katerina Shushropat has asked a question in Q&A Could you please comment on how the refugees from Ukraine are currently integrated in mental health systems of your country? What kind of services and support are currently provided for them? Could you answer this, or is it possible? Probably she means in the United States.
Yeah, I see both of those. Okay, I'll do that question first.
Yeah.
Well, I don't think we have very many Ukrainians right now. We have a lot of Ukrainian Americans, and in Chicago, there's Ukrainian Village, and I know many Ukrainian people, Ukrainian doctors, and I think many of them are very willing to host Ukrainians. They have cousins, they have relatives, and I think many of them are on their way over. What U.S. is trying differently now with refugee resettlement is they're trying to use more of a family host model than an organizational model. So instead of like the organization that I mentioned before, receiving 500 families, you'll have, 500 refugee families, you'll have local families saying, I want to host a Ukrainian family, and there's a process by which families are matched with hosts. So this is a very different system. Nobody knows exactly how that's going to work. It'll be interesting. It'll be interesting to see how that works. But I would also say that our refugee resettlement system in the US was demolished by the Trump administration. The numbers of refugees went way down, as you know, with this Muslim ban and things like that, and a lot of Islamophobia. With the change in administration and other issues, this is coming back now. So now we have large amounts of Afghans and large amounts of Ukrainians apparently on their way. The Afghans many of them are on US military bases because they came in very quickly. They didn't get kind of adequately cleared in Afghanistan. You know the whole disaster of that experience. So they're going through this kind of clearance on these bases, and then they're now being introduced into communities. So that's not the typical pathway in America. So I think we're going to see now, hopefully, the building back of refugee resettlement system. And we actually had a roundtable last week at our university on this topic. And what we asked ourselves is, now that we're building back this system, should we just do the same things for mental health and psychosocial care, or should we also be making innovations, making changes? And we had a very good discussion about that, and some of that informed the things I said today. So we'll see what happens with that.
We put on this webinar, it is a webinar of WACP, the World Association of Cultural Psychiatry, as a preview webinar to the Congress that we will have in September in Rotterdam. If you want more information on that Congress, it's www.wacp2022.org. And the registration has opened today. And there's a pre-conference workshop on this subject as well. So we wanted to look forward to a preview the Congress by discussing this subject, the do's and don'ts for hosting and helping was very clear, I think, Professor Wien. And there was a question that you answered to that person, which was, I think, one part of that question, I hope you can reflect on that, is that a question was, what if a refugee from Ukraine, for instance, has been diagnosed with a mental disorder prior to coming to another country? What services are available, or how is it known, and how should that person receive repetitive care?
Mm-hmm. Well, that's a good question, and there are children or adults too who have what we'd call pre-existing conditions. And the most important thing is that they get linked to care. And and that they get, whether that's through the school, a teacher, a school psychologist, or mental health clinic, or primary care, it doesn't matter, as long as they get properly assessed and treated. And I think a lot of responsibility falls on the parents themselves to make those connections. If the parents don't do it, then I don't know that it would happen otherwise. So, you know, I could think of cases where parents might you know, seek out the appropriate services in a way that was helpful. I could also see other cases where parents might say, well, he or she has been through a lot. I want to give them some time to adjust, and then the child doesn't get the services and maybe starts off on the wrong foot in school. So so that comes down to educating, again, doing education in the community. Refugees often, at least in the US, don't understand what they have the right to do, that their child has the right to services, and how to seek those. So I think it's very important that both health and mental health professionals and other community workers, you know, build trust between communities and service organizations and do education to help promote help seeking. Thanks.
Thank you. Thank you. Julia, for Dr. Bada, when you thank you very much for your presentation. It was perfectly understandable, even without slides at first hand, but then again with slides. For a situation in the Netherlands, you know, it tends to be among mental health professionals, there's discussions going on, you know, they experienced war, but they do not always need help. Do you know anything about prevention or screening activities, or for those who do need help, you know, regarding the high numbers of PTSD and depression, for instance, in the Bosnian refugees that we experienced before, and that Professor Wien has pointed out?
I'm don't know at this moment. I mean, the refugees are here a few months, and I'm sure that in some of them are in reception centers, and I think that there probably is a better way to screen, and many are with the families, and now they are also having possibility to go to doctors. But I have another worry. I think that not all refugees need mental health care. I would be very happy if there would be much more preventive work with mothers, and where that is possible. I have another worry, and that is what I know, that in the Netherlands, it is very difficult to reach the mental health service for the Netherlanders themselves, because the waiting lists are 6 months or 1 year. So that is what I find very important issue, how it can be solved. And I myself have no answer for that yet.
Okay, thank you. And I have another opportunity, because we're talking about United States and the Netherlands, but there is also someone active in Poland, Eva Dobiala, and she says she could add something about the Polish perspective, you know, the country where most Ukrainian refugees seek refuge. Could you please, Eva?
Thank you, Simon. Good afternoon. It was really very nice to listen your lectures, your words, and I was deeply reflecting how it is at that moment in this all what's going on in Poland. I also see some questions in the chat. These questions around how Ukrainian refugees could have any kind of access to mental health service in countries where they are. In Poland at that moment, we've got more than 3 million refugees. For last 2.5 months, many of our cities became bigger for 50%. It means that, for example, a city like Wrocław, in February this year, there was 500,000 people. At that moment, there are 750,000 people. So this situation is like that we really need to look at the whole picture, not only for one single patient, one single human being, one single kid. Only try to distribute our resources as possible. And at that moment in our country, every Ukrainian person has the same access to mental health service as Polish people. Most of Ukrainian refugees live at that moment together with Polish families. So we haven't got too big experience with any kind of camps. There are some, but most of refugees are just in the cities together with Polish families. That's true that everything is around the knowledge about the possibilities of access. But because of the fact that everything is developing from the basis, it means from people to people, not exactly from the system, only from this different side. It gives people the chance to access to the knowledge, I think, even faster. At that moment, Ukrainian kids are at Polish schools for a few weeks. So many Polish schools started to be just 30–40% bigger. And teachers are in this position of this first contact. And it is one of the biggest challenge, to be honest, because for us it is a third really very big challenge. The first was some kind of our social situation in Poland. The second was COVID, and now it is the situation of war. So, it is a little bit like this. But all of these kids and all women, all Ukrainian people have access to mental health service at the same level. I see, Stephen, your wish to say something?
Yes, please respond, Stephen.
No, go. I mean, I don't want to interrupt. Go on.
Okay, I will just say only two sentences about this question about Ukrainian psychologists in this service, and about this part with developmental disorders. So about Ukrainian psychologists, we are aware in Poland that we really need to involve all Ukrainian specialists, because we are in this kind of situation that we just need every kind of support. So in many cities at that moment, we try to arrange this kind of support. In my city, we found some funds to involve 5 psychotherapists, and the service, mental health service, started to be in Ukrainian language, and we understand that it's really very important to make it in just in Ukrainian language. That's also true that we here in Poland, we are in this kind of situation that Polish and Ukrainian is quite close. So I suppose in few months, maybe even it will not be a big problem. According to this question about ASD or another developmental disorders, of course, for us in Poland, it would be really very useful if Ukrainian refugees have some previous documentations, because, well, for sure, everybody would respect it. Also because of the fact that we haven't got so many resources just to re-diagnose only for our need. But that's also true that in kids and adolescent psychiatry, in Poland, the Polish system is divided in two areas. First area is connected with mental health service, and another part is connected with schools. And every kind of support which kid could get from school needs some additional opinion from psychological and pedagogical counseling center. It's some kind of special centers, not connecting with mental health system, only with schools. But this situation is both from Polish and Ukrainian kids. It doesn't, here it's nothing different from Ukrainian, just all kids every few years need to have some new opinion from this kind of centers to get the professional support at school. So I hope I just said these few words around this question. I hope it would be useful. Thank you, Simon.
Yes, thank you, Eva. Professor Wien, you wanted to respond.
Well, that was very informative and thoughtful reflections. And, it made me just want to hear more because I'm sure you are learning, having such experiences and meeting challenges and improvising and innovating. And I would like to hear more about that. Maybe, I hope you might have a chance to, or other providers from Poland or neighboring countries present at the conference in Rotterdam. That would be very interesting. I for one would just like to hear more about how it's organized in Poland, how the mental health services for the refugees are organized, and maybe this isn't the time or place to explain it all, but and it also reminds me of the situation in Turkey, which faced a situation of some 5 million Syrian refugees, and had to also similarly, cities where the numbers of Syrian refugees outnumbered the numbers of residents, and existing services were swamped. Some services were provided through different NGOs, like the Turkish Red Crescent. But I think that's a similar kind of mass population challenge, and it'd be very interesting to understand how the Polish government and civil society is pairing up to address that huge need.
Yes, thank you. And I would like to ask all of you. There was one question from the audience. Many of the Ukrainian refugees are hosted by families, like you said, Eva. Same in the Netherlands. So one question was, how do these families recognize whether there may be mental health problems and someone might need mental help? Maybe Julia, could you reflect on that?
I heard that some families are doing really well, some families are not so very well, but I think that what I believe that it maybe families might support someone to also refer where they have to go and for which problem where they have to knock, even though it's sometimes complicated in the Netherlands. But I think that I believe that through the internet there are a lot of network between the parents, and that they found their way, and if one find that can also help the others, so I believe that they would find their way to where they need help. also through families, through their doctors, or in between with them, in contact with each other. I'm very impressed, Eva, how much is done in Poland in this short time, and it really shows how a lot can be generated, and it's so important that it's going on many levels. So my appreciation, really.
Thank you.
Yes. Do you know about the families? Are they aware of? Is it you know? Maybe there's a stigma in Polish population as well?
Well, this Polish situation is a little bit different, I think, and I'm sure that we will talk about it really very differently in half year, in 1 year, in 2 years, because these narrations are still changing. What was the most different from the very beginning, it was the fact that it's not exactly that our country invite these 3 million people, Polish people invite these 3 million people. Of course, at that moment, country tried to find some system, but still it's really in process. So this first reaction was just human reaction. It wasn't connected with any kind of system. And it was great and it was difficult at the same time. And for sure, there will be a lot of research about it, what is really done for all of us. And it's even difficult for me at that moment to talk about it because I still have a lot of emotions and I still haven't words, to be honest, really very, very correct words. Trying to come back a little bit, Simon, to this your question. What I see, we in Poland, we are a little bit different place in our relationship with mental health service than Ukrainian colleagues who came to Poland. Because in last 10 years, maybe even 20, there was, we could observe the process of integration and assimilation, the idea that mental health is useful and psychiatrists could be supportive, and there are psychotherapists also and psychologists. I wanted just to say that Polish society started to be much more open for this kind of support. And the knowledge in the Polish society is much bigger at that moment than it was 20 years ago. So for sure, this meeting, family with family, open a lot of space just to share and exchange this kind of knowledge and this kind of possibilities that you could really try to find support if you discover any kind of suffering inside of yourself. And I see it in my city, that many patients, many Ukrainian patients coming to us with some kind of support of Polish family. First, there is a phone from Polish family, okay, that there is this kind of situation and we just looking for help. So here I see this kind of dynamic. And of course, we try to do some psychoeducational programs, also for Polish people, because it is a process. And Ukrainian society is quite close for us at the cultural level. And this their trauma, I use this word trauma because, well, very often it is trauma, makes a lot of re-traumatization in Polish society and even secondary traumatization. And it's this process which we started to observe, and it's a little bit difficult for me to say something about it at that moment. Probably we'll be able to say more in 2 months and 3 months, maybe in half a year. I see this process in schools, for example, when classes were for 20 people, 20 kids, and now there are 30. There is a big challenge with all these kids who have some developmental challenges. Well, it's a lot of processes which at that moment we just observe and we try to react for them. But this reaction is really, it's not systemic. We haven't got any kind of system. So if we've got a smart school with smart teachers, we've got this kind of schools. Well, then it's going on. If there are more overwhelmed teachers or even burnout, then, well, so it's really all kind of dynamic at that moment. We could see all kind of dynamic.
Okay, thank you very much, Eva. We also had a contribution in the chat through Dr. Rachel Tribe, who's with us. A very well-known WACP member also, and she provided a website with mental health support for refugees, both mental health and well-being, and we will share it in the entire group, and also in afterwards maybe if you share the video. And I also with us is the president of the WACP Congress in Rotterdam in September, Professor Braakman, who also like to express a few words.
Thank you so much, Simon and Hans, for organizing this on behalf of the WACP, and especially thank you, Stefan and Julia, for sharing your knowledge and experience with us today. And you know, as president-elect of the WACP, I just want to stress that what's very important to us is solidarity among us as professionals working in mental health care to improve care for our patients. And it is very essential in these difficult times we are facing now. And Stephen said it very aptly that I like to hear more of that, he said. And fortunately, in September, we host a very big conference in which we have 4 plenary sessions, in which we have 61 symposia, and in which we have 247 presenters, and we have 8 pre-conference workshops, a very nice social program. It's all happening in 4 days in Rotterdam, 14 September, 15, 16, and 17. And I hope we will continue our discussion over there because there is so much more to talk about. And I very much hope to meet you all there in person, because after COVID, we need to inspire each other, and we can do that by talking to each other in person and have a cup of coffee together and talk about our patients and how to improve our mental health care for them. And thank you very much for attending tonight. And as WACP, we are very proud of this seminar, and a lot more will follow. And follow us on wacp2022.org.